probably a good number. So everybody, welcome to our third session of AO North America Link. Tonight, we're going to be journeying into the realm of pediatric orthopedics, which has its own perils and pitfalls, but can be really interesting also. So tonight, we're talking about elbow to Tillaux. And what's a Tillaux? We're going to find that out, but really it's an ankle. It's just a fancy way of saying an ankle fracture in a kid, but it rhymes with elbow, and so that's why I went with it. All right. So many of you all at least have been along the ride with us for a little while now. AO North America Link's all about listening, integrating, networking, and knowledge as we work to provide you with that foundational orthopedic knowledge to navigate your early careers here. We really appreciate the support of Dr. Lee and Dr. Kapatkin in the AO North America Link program here. And as always, we've got our shepherd, Dr. Aker, here with us tonight. Any words, Dr. Aker? Just 2 thumbs up. I love it. Yeah, that works.
I'm just super excited that we are exploring just the trauma world.
There we go. And then Phil's going to be answering questions in the Q&A box. And I'm here back from vacation last month. Bummed to have missed out on the arthroplasty discussion. Dr. Ward and Dr. Roper join us tonight. Guys, how about you give us an intro, and how about maybe, I guess students are probably anxiously awaiting to hear about interviews, but maybe they're starting to prep. So maybe some advice for students as they're doing interview prep.
Oh, yeah, absolutely. Well, my name is Norman Ward. I'm a pediatric orthopedic surgeon. I'm actually going from Texas Tech El Paso to Charleston here in the near future at MUSC. Love doing pediatric trauma. Happy to talk to you guys tonight. One thing, you guys, right now, you're probably finishing up your rotations. You're probably getting to the point where your applications are submitted. Basically, the international interview invite date is going to be, it seems like Universal Interview Day offer is on November 18th. So be mindful of that date. Be around, be ready. Just be patient, though.
And so I'm Brendan Roper. I am also very happy to be joining you guys tonight. I appreciate the opportunity. I'm excited to get to talk to y'all about some pediatric orthopedic problems and issues that we frequently see. I trained at UT Houston under the tutelage of Dr. Aker. Whether he will claim me or not depends on how well we teach this lecture here tonight. And actually came back in and am now working at the University of Texas in Houston. And so really looking forward to chatting about topics that we have on hand. I think best piece of advice for you guys, try to enjoy the process. I know that sounds silly as you're going through the interviews and it's stressful and you're trying to get everything in and you're trying to understand where you're going to be spending the next 5 years, but enjoy the process, enjoy the interview trail, get to know other people going through that same process as you, really get to know the residents at the places you're interviewing, because those are the people you're going to be spending the vast majority of your life with for the next couple of years. And so take a second to sit back and breathe and enjoy the opportunities and the relationships you're going to make the next couple of months.
Sure. It can be a whirlwind, but don't forget to take a look back there. So we've gone through a couple of things. This is a schedule looking ahead, but tonight it's Peds Ortho. So we're going to dive in pretty quickly here in a sec. Don't forget to check out AL Milestones coming at you soon. Don't forget to use the Q&A box to get all your questions answered. Phil is looking like he's really pensive and ready to respond to those questions. And then don't forget to watch again. Everything's uploaded on YouTube. Don't hesitate to look back. If there's a concept maybe you didn't understand, you want to watch it again to rehash that out. Also, all the lectures from last session are on there as well. So just a quick recap of the month I missed. Arthroplasty, we covered a lot of things, but a lot of crazy and cool x-rays from when I was looking through those slides. One of the things you learned was how to differentiate a hemiarthroplasty from a total hip arthroplasty, which is super important, as you can see on the x-rays here. And then differentiating knee implants as well, cruciate retaining implants versus posterior stabilized implants, and why that's relevant to what we do in orthopedic trauma when you're looking for that open box, because we all want to put retrograde nails in distal femur fractures now. And then looking at dislocations and trying to figure out which direction is the hip dislocated so you can figure out how you reduce that when you're seeing that consult in the ER. And then also we learned a little bit about how periprosthetic joint infection is a challenging problem in the arthroplasty world, and there are a very specific set of criteria by which you diagnose that problem. And then you guys also went through some really awesome cases on periprosthetic fractures and how a lot of our AO principles translate into that realm, but how we really dive into the toolbox to solve really complicated problems. But tonight we're flipping things around and going to the totally different end of the spectrum here and talking about pediatric ortho. And what we really want you to understand is that kids are different than adults. There's no doubt about it. They're not just small adults. And we're going to have you understand and recognize why that is. And then we're also going to teach you about the Salter-Harris classification system. We want you to be able to draw on that knowledge as you talk about these fractures when you see these sort of consults, and then recognizing and managing common peds elbow and peds ankle injuries. And so let's dive into it. Just a quick little intro on some general topics related to pediatrics. There are definitely some unique challenges in the exam and overall assessment of these patients because they may not always be able to follow your commands. They may not do what you ask them to because they're fussy or they can't understand you or any number of things, or they can't communicate that well. And so sometimes you really have to observe the patient and see what they're doing, maybe distract them a little bit, maybe even play a little game with them, something like that, to really get to the exam findings that you need to make sure that they are neurovascularly intact and really assess them appropriately. And then one of the most important things is really making sure that the history coincides with the injury and the x-rays that you're looking at, because there's one thing you don't really ever want to miss, and that's non-accidental trauma or abuse, because if a child stays in a situation in which that is occurring, then more harm could happen. And so you really have to pay attention to some of those subtle details. Probably one of the other things that can be challenging with peds patients is dealing with parents and managing parents, because obviously they're very worried about their child, and rightfully so. But how do you guys, any tips for sort of dealing with parents?
Oh yeah, you're basically educating the entire room. The first thing you want to do when you're going into a kid's room is to basically gain rapport, talk to the family. Don't even mention the fracture. Don't mention the injury, because the second you walk in there and just go grab whatever hurts, they're not going to trust you. So you want to take your time, get on the patient's level, make some jokes. This is pediatrics. We have fun. So you know that the elbow's broken, the ankle's broken. You don't have to go mess with that first. Go talk to the family, sit on the bed, talk, and basically build build some trust in the family. And the more you're able to kind of describe things, or at least let the parents know exactly what you're doing before you do it, it'll make things a lot more smoother, especially if you're coming in as a medical student.
Does that include your Halloween costume? I'm sure you got one picked out. You got.
Oh, we always dress in pediatrics. We are dressing up as let's see, Inside Out this year.
Oh, there we go. Nice.
Nice.
So Brennan, obviously there's a big scientific reason that kids are different, and that's the growth plate. Will you take us through the physis and why it's important in this context?
Of course, yeah. And so as you guys get through, obviously you've been through the medical school route and you've been through step one, and you've seen diagrams like this, and you probably still have nightmares about diagrams like this because there's a lot to read about and to try to memorize. The big thing to take away from the physis in this context is that it really provides some different parameters for how we're looking at injuries, number one, and then number two, what are our goals for treatment for these patients? Ultimately, if we're looking at adults, if we're looking at kids, our goals are appropriate length, alignment, rotation, and restoration of normal function for these patients. We have an additional tool in our toolbox in the pediatric world, and that the physis helps us with that most commonly. And so understanding how the physis works, how it grows, and how it contributes to these injuries and the healing of these injuries is super important. Yes, for testing purposes, it's important to understand the different levels and the different stages of the physis. You should know that there are different areas that are more prone to diseases or to fractures, and knowing that is a critical component of understanding the full pathology of injuries. But for tonight, we're going to put that PTSD of memorizing these types of pictures behind us and just know that the physis is really important in the trauma setting for three main factors. Number one, helps kids grow. And so with growth, we have obviously achieving a more adult skeleton. Number two, specifically about fractures, we can utilize the growth of that physis or that growth plate to maybe not necessarily need to intervene surgically as often, but rely on that growth and the remodeling potential of those bones to heal fractures in an imperfect position, and then with time, create a more normal bony morphology. The downside of the physis being there are some side effects or some complications that can come from the injury of the physis, where it's no longer providing that benefit to us, and sometimes can result in less than satisfactory complications. And so we'll kind of go through all of those. This first slide is really looking at the positives. And again, the physis is your friend. It helps you quite significantly as far as seeing fractures to a healed position and making sure that kids get back to their normal function. The big difference here is a lot of times in our adult trauma patients, we are reconstructing to the point where we have a perfect reduction. So we're getting them back to what that bone looked like before the injury ever happened. And most of the time using surgeries to accomplish that. In the pediatric patient, it doesn't have to be perfect. And commonly, based upon the physis that we're around and the age of the patient, we can accept an imperfect reduction and then allow the remodeling process as the bone heals imperfectly and then continues to grow. The body, using cues from the shape of the bone, the function of the bone, and the forces that come through that area, will actually reshape that bone into the proper position so that we achieve the functional status that we want. We can see here a proximal humerus fracture that is 100% translated, slightly shortened. And in an adult patient, this is most commonly at least getting a reduction, if not some surgical fixation. But in the pediatric patient, this is one that can heal. You can see the bridging callus progressively consolidate throughout these images. And then with time, you're seeing that normalization of the humeral shaft. That's one of the huge components of the physis and why it's so important, why it's so beneficial for us when we're looking at trauma patients and deciding who needs to be fixed, who doesn't need to be fixed, and how do we manage this moving forward.
Perfect. Yeah. And you touched on some of the drawbacks of the physis, or at least injuries around the physis. And we do have to consider those in terms of disruption of that growth, and then angular deformity or leg length discrepancies that may develop that you may have to deal with later too. And so then also there are various factors that may influence how these injuries remodel, including how much growth is remaining and the patient's skeletal age versus their actual age, the proximity of the injury to the physis itself, as well as the growth contribution of that nearest physis, as well as the plane of motion there. Anything that you would add in regard to remodeling beyond those things, or is that pretty comprehensive in terms of how you think about things?
Yeah, so these are really the four main take-home points of why we're looking at different injuries differently. So a proximal humerus fracture, very different than a distal humerus fracture. And the reason being, as we can see on the screen here, that proximal humerus growth plate contributes 80% of the growth of the humerus versus only 20% distally. And so the more growth you have at a physis, the more remodeling potential, the less likely that you need that perfect reduction or that perfect alignment. The other big one is the plane of motion. And so we'll talk about supracondylar humerus fractures here in a moment. Flexion extension deformity can remodel actually pretty well in younger kids. But if we're talking about a coronal plane deformity or an angular deformity, varus or valgus at the elbow, that does not remodel well. And so really understanding these principles, again, is going to guide your decision-making as far as operative versus non-operative and how to educate the family on what to expect moving forward.
Perfect. That's super helpful.
I'll just put a quick plug in because I love that Dr. Roper showed that proximal humerus is so much translation. It's really displaced. Sometimes managing the fracture is really not that complicated, but managing the parents in that situation, in my experience, has been challenging. I've had several of those proximal humerus fractures over the years, and you know that everybody wants to see the x-ray of their child, and then they almost think that like you're a fraud when you tell them this doesn't need surgery. Like no parent wants surgery for their child, but they want their bones to be lined up. It's sort of like a leap of faith. You have to get them on board to understand that this is going to work. You just have to be patient, because a lot of parents are awfully confused when they leave the clinic after seeing that x-ray.
Yeah, you are
Oh,
spot on. No parent thinks that a hanging arm cast in 6 to 8 weeks and their kid's going to be moving perfectly when they see those x-rays. So helpful to have previous examples. As my receding hairline grows, I think that gives me a little more credibility. But the first couple of years when you're in practice, the young practice, it is a challenging discussion sometimes.
Oh, I bet. So Trey, will you take us through the Salter-Harris classification as it relates to the physis?
Yeah, let's go ahead and talk about that for a little bit. But let's go ahead and get everybody on the same page. Remember from medical school, your anatomy. Hopefully, you're able to remember that there's a diaphysis, there's a metaphysis, there's an epiphysis, and these structures are. I'm going to use these words quite a bit as we talk about this. But the way that we go through the Salter-Harris classification is just where did the force propagate through the leg? Where did it propagate? Or this is an AP view of the knee, but where did the force propagate through the physis, and where did the force exit? So for a Salter-Harris 1 fracture, you're going to have one that goes completely through the physis, and that's what's shown on the left-hand side of the screen. A Salter-Harris 2 fracture is going to be one that starts in the physis and then exits through the metaphysis. So you have some tension on the physeal disruption side with a little bit of compression on the metaphyseal side. A little eponym for you to know would be a Thurston-Holland fragment, and that's what the metaphyseal portion of a Salter-Harris 2 is. A Salter-Harris 3 fracture is going to be one where that same force was applied, however, the force propagated down through the epiphysis. And I say down in this distal femur, however, if this was a proximal tibia fracture, it would actually be going up into the epiphysis. So you can't just use above or below, you need to know that where the fracture line is actually going through. Salter-Harris 4 is going to be one that's completely disrupting both the metaphysis and going through the physis and into the epiphysis. Those can be really disruptive. You normally see those typically around the ankle, along the medial side. However, those are ones that can be seen through any physis. And then lastly, the type 5 is going to be the crush injury, the one that you're not going to really see as well on X-ray, except for maybe after the fact, maybe 2, 3, 4 weeks after the fact, and all of a sudden you had an axial load that compressed the physis, and then you end up with a physeal rest like we were talking about before, and you see this callus formation that's going on. So the way that we describe these fractures are going to be majority of the time utilizing this type of classification system. And it helps you if you use these types of phrases when you're describing fractures. So we as faculty know that you know what you're talking about. You know what it means when something is a Salter-Harris 2 fracture. You know if you're presenting a distal radius fracture and that's a Salter-Harris 1. We know in our mind's eye, we know exactly what you're talking about. And that kind of brings us to our first case here. This 14-year-old male suspects a football injury, is tackled and presented to the emergency room. When it comes to the emergency room, we obviously want to X-ray the thing that hurts the most. And for this patient, the patient's knee was hurting. We also want to make sure that we're not missing anything else proximally and distally. So getting the joint above and joint below. I think you guys talked about it previously, but being able to concisely get an exam and concisely relay that information to your faculty or your resident is going to be very valuable. So that age, sex, mechanism, injury, pertinent positives, treatment plan sort of presentation is what you kind of want to stick to. 14-year-old male status post football injury, sustaining a closed. I'm going to go ahead and tell you that this is a left Salter-Harris 3 because the fracture goes through the physis and down into the epiphysis. Salter-Harris 3 fracture with no medical comorbidities, the limb is neurovascularly intact. Then treatment is going to be we place the patient into a posterior slab splint. We're obtaining a CT scan in order to see the articular disruption, which is what you can see on the right-hand side of the screen where it exits into the epiphysis. And then the plan for me would be to obtain an articular reduction. And because we have to take considerations such as the physis into consideration, we need to make sure that our treatment plan coincides with this. And typically, we don't want to put things through the physis if we're trying to keep that physis growing. Sometimes we do it on purpose. Sometimes we're trying to correct an angular deformity. However, if we're really concerned about the articular reduction, if we keep screws within the epiphysis, and we don't traverse the physis, we can achieve our operative goals and ensure the patient has a good outcome in the future. So yes, this was Salter-Harris 3 that I treated and went on to uneventful radiographic and clinical unions.
So Dr. Ward, can I ask you a question about this case?
Of course, as you should.
So I just got done talking about how kids don't always have to have surgeries, and a lot of times they can remodel injuries that occurred. And if anybody was briefly looking through the distal extremity, they know that the distal femoral physis is the most active, so we could expect the most remodeling there. So why do we fix this fracture here? What's so important about getting this fracture fixation perfect?
One of those that we described was one of the things I described, like the articular reduction. That's absolutely important in articular fractures in order to prevent things like pain, arthritis, non-union. However, in regards to the physis, we need to respect it. We need to try to reapproximate it as much as we possibly can in order to prevent the bad things. And you did say that the distal femur is very active, but it's also unfortunately very prone to physeal arrest. And if you do not reapproximate that physis and get it as close as you possibly can to where it used to be, then you can have evidence of angular deformity. And actually, this patient was followed for approximately a year and a half in order to ensure that they did not have a physeal arrest. And the way that that would present would be that there would be tethering on the side of the physis that was disrupted, the medial side, and then the lateral side would continue to grow. So you'd end up with a distal femoral varus alignment. So that's a good point.
Yeah, this is a little bit of a callback to some of the older link lectures, but this is absolute stability with lag by design with those partially threaded cannulated screws with washers there.
Absolutely.
Next, we're going to jump into elbow fractures, but I just want to give Phil a quick sec if there's any questions that we need to address really quick.
No questions, except I do have two. First, Brennan, why do kids fracture so commonly through the physis? So like it has its own classification, like is that a weak area of the bone first? And then secondly, in that distal femur case, let's say I didn't listen to this lecture and I did plate across. I got out my distal femur plate and plated across the physis. How would that have any impact on the patient?
So I think it's important to understand that the physis is a beautiful thing and that it allows us to grow, it allows for remodeling, but it also is a inherently somewhat weaker portion of the bone because of the different makeup of the cells there and the makeup of the biomechanical structural stability. So unlike a solid diaphyseal cortex where we have that strong stability in the bone, there is active change in cell type and active progression in cell type at the physis. And so we are higher risk of fracturing through that area just because the inherent somewhat weaker nature of the biomechanics of the bone there. And then to your second question, certainly could we plate something like that? Absolutely we can, but the concern is if we are fixing across a physis, whether we are directly putting screws or wires or something traversing the physis or a plate that spans the physis, that will tether that area of the physis. And so it's like holding something that wants to grow, but holding it back from growing. And so depending upon your construct, if you are simply on one side, so on that side, just on the medial side, you could see restricted medial growth with normal growth laterally, or you could see a complete restriction of both the medial and lateral side of that physis, resulting in a growth difference or a limb length difference in that femur. And so if we can appropriately and stably fix fractures without violating the physis, without bridging the physis across the physis, we try to do that. If we can't do that, we still need an appropriate articular reduction. And so sometimes we do have to do fixation across the physis, and then we just take that out before we really affect the growth.
Check.
Perfect. Let's dive into elbows here. So these are the three most common types of pediatric elbow fractures that you may encounter in the emergency room. That's a supracondylar humerus fracture, a lateral condyle fracture, and a medial epicondyle fracture. Pardon me. Brennan, would you take us through the most common type, the supracondylar humerus fracture?
So anybody who's taken orthopedic call as a med student, as a resident, as an attending, if you are taking care of children, you will see a supracondylar humerus fracture. This is the most common that we see in all of pediatric orthopedics. Happens anywhere from, the most common is from the 4-year-old to the 8-year-old, but you can see it as young as the 2-year-old. You can see it as old as the 13-year-old. So really throughout the gamut of childhood, we can see these injuries. And again, this is just following biomechanics. There's a slightly weakened area in the supracondylar humerus as we're traversing from the strong diaphyseal cortical bone to the large articular block. And as we come through that smaller area of the bone, or the decreased surface area of the bone in that transition from diaphysis to articular block, that's where that bone is weakest. And so fractures through there commonly occur. Most common of these are extension fractures. So we land onto an outstretched arm, we buckle back, we have a tension-sided injury to the anterior surface and more of a compression side posteriorly. You see that articular block swing posteriorly, and that gives us our extension deformity. And then you'll see some coronal plane disruption or translation dependent upon the amount of soft tissue injury and the instability of that injury as well.
Perfect. And then as we classify these, how do you think about the classification system in sort of I guess, simple terms?
Yeah, just like everything else in orthopedics, the classification system should serve a function. So number one, it should help us understand the morphology of the injury, but number two should direct our treatment. And so it's really classifying between the non-displaced fractures, the minimally or lesser displaced fractures that still have some intact stability to them, like our type 2s, and then those that have significant soft tissue disruption. And so there's a higher degree of instability, which certainly helps us understand we may need a little bit more for the surgical fixation of those to regain that stability in that area.
Perfect. And then as you see these patients in the ER, what's important that you don't want your residents to miss or students to miss when they help out seeing these consults?
Yeah, so even though this is the most common fracture that we're seeing come through, there are bad players and not so bad players. And certainly the more displaced and the more soft tissue disruption that you see, the more risk there is for additional injuries. If you think about your own elbow and you think about a smaller version in a kid, you can understand it's pretty tight quarters with nerves, vessels running all through that area. And there's not a whole lot of room if we have a whole lot of displacement or a high energy fracture pattern. So you can see here a posterior medially displaced fracture, a supracondylar humerus fracture. And the diagram next to it is showing that that brachial artery and the median nerve running anteriorly is actually being pushed on by the proximal fracture fragment. So the tension-sided failure of the fracture is causing that potential injury to our neurovascular structure there. In the clinical photo, you can see the result of some of that soft tissue injury when we have the fracture pierce through some of the musculature. We can see what's called a puckering sign, and we can see ecchymosis in the antecubital fossa. All of those are indicative of a much larger soft tissue injury. We need to be much more concerned about potential vascular or neurologic injuries at that point. Going back to your first part, we want to make sure that we have a very good neurovascular exam for these patients. That is more challenging in the younger patients, but really making sure that you take time playing with the kids, using toys, using parents, using others to facilitate that exam so that you can understand the degree of the soft tissue injury in association with the bony injury as well.
Perfect. And then that brings us to our first case here. This is a great supracondylar humerus case. It looks pretty similar to that x-ray on that last slide. This is a 6-year-old female that fell from about 3 feet. I think this is your case, Trey.
Yeah,
Would you tell us a little bit about the assessment and strategy here?
of course. In the emergency room, you're going to expect this posterior lateral. Remember, we use the distal segment to describe the displacement. So it's posterior laterally displaced supracondylar humerus fracture. And a 6-year-old, there was ecchymosis puckering along the anterior medial cortex and anterior medial skin. The main things here are going to make sure that because the spike is anterior medial, you're making sure you're assessing for your vascular status, you're assessing for your anterior interosseous function, your flexion of your thumb, or your FPL. And then lastly, this patient was placed into a posterior subsplint in the emergency room and then underwent percutaneous pinning by me. What I'm using here, that my thumb there, is trying to reduce the fracture, put the fragments back to where they used to be, and hold them in place with these pins. The big things here are that I'm using the intact periosteum on the posterior lateral side, the compression side, in order to reduce the fracture. And then that's where my thumb is pressing. That's where it's manipulating the fracture, because the tension side is the anterior medial side. My pin construct is a divergent pin construct, all entering from the lateral side through the capitellar ossification center, which is that circle at the very bottom. That lateral x-ray that you're seeing on the right side is what your goal should be. You should have the capitellar ossification center bisecting the anterior humeral line. If you drew a line straight down the anterior humerus, it should go through that capitellar ossification center. So overall, I think this patient had a good result, and at 10 weeks had evidence of full callus, full bony union. You can see that extra little callus on the lateral side, and that's where you can know that there's bridging bone. But
Yeah, it's pretty crazy that they heal so fast.
yeah, it's the supracondylar region does quite well as long as it's held in position.
So we're going to dive right into our next case, actually, because it looks pretty similar to me. Is this also a supracondylar humerus fracture?
I mean, they came in the same way.
Something?
They fell and they landed on their arm. Their arm still hurts. It still hurts on the same side. It's still swollen. Doesn't want to move it. But this is a little bit different. This is one that you're going to take a extra minute and realize that this kid is in pain. They have swelling and edema, And there's little things. These are little tiny findings that you're going to see on these x-rays. In particular, in this age group, maybe a little bit older too, you're going to start seeing things called a lateral condyle fracture. And this is where that little fragment that's circled on both those images is going to be really important. We're looking for the displacement. And that x-ray on the right-hand side is a special view. It's called an internal rotation oblique view, or internal oblique. Your standard x-rays you get for an elbow, or same as every other joint, you get AP lateral and some standardized oblique. But that standardized oblique is an external rotated view. You have to actually ask specifically to get that internal rotation view. And so you need to be mindful of that, especially if you have a patient where things are not quite clear, you don't really see the fracture very well, there might be a line, there might not. Go ahead and get that x-ray, get that extra little bit in order to check to make sure you're not missing something important, because those can be little tiny things, or they can be these big fragments that we're pointing to here on the right-hand side. The bigger things here are that we're really, once again, caring about that articular reduction. We want to make sure that the fracture at the end of the distal end of the epiphysis, right where the articulation is well aligned and held in position to allow for nice, uneventful healing. We want to make sure that there's no articular step-offs, there's no evidence or no potential for non-union, because that's a really bad outcome in kids. Look up fishtail deformity after this is done. You'll be able to see some examples of how bad these things can go. But let's go back to this kid. These are the 3 x-rays you got in the emergency room, and then the internal oblique. Those 3 views are what caused the radiologist to read this as a supracondylar, a type 1 supracondylar. But this is a lateral condyle, and it takes a different type of treatment. It actually was presented to clinic and then had a little bit of displacement. And so this is what's called an arthrogram. This arthrogram is where we inject dye into the joint in order to see all the structures you can't really see normally, because we're using all these little flecks of bone to represent potentially bigger fractures. This arthrogram lets you see exactly how big that intra-articular block is, because the biggest thing I care about is that little oblique line in that center image that goes down towards the articular surface. And that's where I'm using to make my decision about whether or not I need to make an incision and open to take a look at the reduction, or else can I just use some blunt manipulation with K-wire fixation in order to make sure that that fracture doesn't further displace. And so these types of injuries can be treated with a number of things. This patient went on to radiographic union. You see a little bit of spurring on that lateral side, that little spike sitting out there on the right-hand side of the left AP view. It's where the periosteum was torn. So you have evidence of disruption. You know there was a real injury after everything's all healed, and you weren't just seeing random lines on that arthrogram. So this is something where we could have potentially potentially prevented a bigger problem. But when you have these types of injuries, the main thing is, especially in the emergency room, diagnose. You got to make sure you're not just writing it off and not getting the full workup.
I think someone would say seek disease and not
Seek
hope for wellness,
disease.
maybe.
Yeah. So there's a lot of different ways you can treat these. There's some debate about how you treat them. But the biggest thing is getting that articular reduction, compressing, not compressing. Some people use screws, some people use wire, some people use both. And they all have their different reasons as to why they think one works better than the other. But the main thing is diagnosing and not missing these and knowing that they're operative.
Perfect. And so
It's
just
important.
oh, go ahead. Sorry, Brent.
I think important, just like our distal femur, this is an articular reduction. We can't rely on remodeling of articular reductions. And so the anatomic reduction here is necessary. And so understanding these injuries makes a difference for how you're going to fix them.
Taylor, a lot of the medical students that are logged on are going to be interns in a few short months, as God willing, they match into orthopedics. And as if orthopedics, the language, the interpretation of the x-rays, as if it's not hard enough, now you sprinkle in some pediatric x-rays, and Lord, trying to interpret some of these things can be really challenging. So one thing that used to help me an awful lot as a resident, as I was learning what is normal before you can recognize abnormal, is to order x-rays of the contralateral elbow, the contralateral femur, whatever is injured or whatever you suspect may be injured. There's a lot of weird lines and you're not exactly sure the ossification. This patient's 5. Are they supposed to have a line there, or is that in a 7-year-old or a 5-year-old? We'll just order the opposite joint and then compare them. And sometimes it becomes so obvious once you have a mirror image to compare it to.
Oh, for sure.
That's helped me a lot in residency.
Absolutely. That's an excellent point. And, I would also add, we may throw stones at our radiologists occasionally, but depending on where you are, if you can get to that reading room and maybe talk to a person in
Yes.
person, oh my goodness, such a foreign concept. But sometimes you'd be like, hey, what do you think about this? And then you may have them reconsider. I don't know. And so
Yeah.
sometimes two brains are actually better than one, even if one is an orthopedic surgeon. So just maybe think about talking to your radiologist as well as ordering that contralateral film. And so just a quick recap. Kids are not just small adults. We learned many reasons why. And then you learned about the 5 types of the Salter-Harris classification. And then we talked a little bit about supracondylar humerus fractures and lateral condyle fractures. And so, Phil, any questions that need to be addressed before we move along?
No, I have one point of clarification. If you could go back to the distal humerus, the arthrogram, because we
Yeah.
looked at Salter-Harris and a physis, and in that child, I could see the epiphysis. I could see the joint. I could see the displacement. I could see the articular incongruity. I could see that it needed surgery. But I think an important point with this is that football player was like 14 or 15, and so his epiphysis had ossified. So this is like there are little blebs of bone in there, I guess. So what is everything else made of that's below the physis? Like, why can't we see it on X-ray?
Oh, it's a cartilaginous analog. It's basically it's the unossified epiphysis. It's going to start popping up. We're going to probably talk about it here in a second. But
Yeah,
how
we'll get.
these different centers, the secondary ossification centers, start blossoming and start appearing, and then eventually they'll fuse into the adult humerus. Like, there we go. Yeah.
Perfect. Just that arthrogram shows it looks like a normal humerus. It's not like a child's elbow. It's just these random blebs of bone.
Right.
The appearance is a humerus that could have an intra-articular fracture. The arthrogram, if dye goes through this cartilaginous onlog, whatever that means, but that would show that the joint, that there's space, that there's displacement that we could see on the X-ray, but now it has dye going through the fracture line. So just a point of clarification for me, because it's been a heck of a long time since I've seen a peds elbow film, but it looks like we're about to hit some of this stuff. So thank you.
Yeah, I mean, I would agree with you, Phil. Like that, I always found this confusing in residency. You're always trying to memorize this stuff. So this is certainly an important component, and maybe you can tell us a little bit why, Brandon.
Yes, Dr. Mitchell and Dr. Aker, very wise because they led us right to this slide without even knowing they were doing so. The pediatric elbow is still, even as intending, it's one of the more challenging things to look at because not only do you have these multiple ossification centers, but you have differences from child to child. So a 5-year-old is not a 5-year-old is not a 5-year-old. So it's important to understand 2 main components. One is that, yes, these ossification centers should start to show in a sequential fashion. There's multiple different acronyms out there that you can use. I used CRITO. I have some partners who used a dirtier version with the CRM-TOL that we'll not get into tonight. But it's just understanding you should see the capitellum ossify first. You should then see the radial head ossify next. You should then see the medial epicondyle ossify next. And so if you're seeing a break in this natural progression or natural order of ossification centers, you should be alerted that something's wrong. Dr. Aker is spot on that 100% the other side is your best friend because there's not a better comparison than the same child on the other side. You can compare a 5-year-old boy to another 5-year-old boy, but they may be in different stages of growth, but they should not be in different stages of growth from a right elbow to a left elbow in the same patient. And so using these mnemonics is helpful. I think the next slide goes through kind of just the full written version of what ossifies first, what completes its ossification, and there's a little bit of variance in those progressions. Understanding those is great, but really understanding the progression so that you're not seeing one ossification center that should be after one that you're not seeing, and we'll get into that with medial epicondyles, but also understanding that the other side is most valuable because you can see exactly where that kid's native anatomy should be. That leads us right into our medial epicondyle fractures. So commonly this is an injury that has a high risk of being missed. And the reason for that is commonly we don't see an ossification center on x-ray, and that is described as, oh, they're just a kid. They probably haven't shown that ossification yet, or it hasn't started ossifying yet. So these are commonly injuries that patients come in with a fall during gymnastics or during sports onto the elbow, potentially elbow dislocation. They're reduced. They have a little swelling, a little pain. On x-ray, it's described as no discrete fracture, and then they're either sent home or they are referred to our clinic. It's really, really important to understand, as you understand the age of these patients, what ossification should be there. And if you're not seeing them and you get the contralateral side and they are there, you need to look hard for them. And so in these x-rays, you can see that medial epicondyle piece that's either circled or pointed at, clearly not sitting next to the medial condyle or its native place. And so this is a fracture that's been entrapped in the joint space. Certainly an indication to relieve that trap fragment and then usually proceed with fixation. Again, just like lateral condyles, these medial epicondyles can have some different views that are beneficial to you. The distal humerus view is a plain film radiograph in which you're looking down the shaft of the humerus, and that really just helps you understand the A to P translation of these injuries. Previous to that, there was discussion in a paper that discussed getting CT scans for these. Commonly, the AP translation of the fractures is not well assessed on normal native radiographs. If you go back one slide, you can see it's very difficult sometimes to see that fracture fragment on the lateral if you're not looking for it. And so CT scans can certainly show where that fracture fragment is, give us a little bit better understanding of the displacement. But certainly in kids, if we are trying to minimize the radiation dose to them, CTs on everyone's not the best idea. So utilizing some of these other plain film views is very helpful. And so this is just another case to run through quickly. This is a 10-year-old female with a gymnastics injury. She was performing some type of acrobatic event, felt a pop in her elbow, had significant swelling, ecchymosis, and pain. And so we see the question, or we see the injury here with that medial epicondyle piece. And if you really look closely, you can see that that's flipped about 180 degrees from where it should be. And then certainly there's some translation from its native bed. On the lateral, again, just demonstrating how difficult these are to see sometimes on the lateral view. That piece is actually about 1.2 centimeters anteriorly translated from its native bed. But because we have so much bony architecture there, it's hard to see through that and really see that fracture fragment independently at times. Important, again, as with all these injuries, understand neurovascular status, understand what's around there. And so that ulnar nerve running right behind your medial epicondyle, if that piece is entrapped, you can see some entrapment of ulnar nerve, or you can just see some paresthesias that go along with that due to the violence and the trauma of that injury there.
So you decided to fix this one because of the fact that she was a gymnastics, because it was flipped, all of the above, essentially?
All of the above. So she was a gymnast. She wanted to get back into activities. The fact that that epiphysis was, or excuse me, the medial epicondyle was flipped 180 degrees did not bode well for appropriate healing. And really, if you measure out her translational displacement, it was pretty significant, greater than a centimeter in both coronal and sagittal planes.
Have you seen much ulnar nerve irritation in these injuries?
So less frequently than you would imagine. With that medial epicondyle being right next to the ulnar nerve, I would expect to see more. But a lot of these kids had maybe a little bit of paresthesias or tingling at the time of the injury. Certainly enough of the violence of the injury, the soft tissues around there see that as well. But usually within a day or two, that has settled down and we're not seeing any residual ulnar nerve symptoms.
I presume because, we saw a lot of K-wires going in and percutaneous surgery here, you're probably not doing that, I would imagine.
Correct. So for medial epicondyles, or if we are fixing supracondylar humeruses with medial pins, because of the closeness of that nerve, it's really important to make sure that you are not entrapping that nerve either in the fracture site or even worse, poking it with a wire or with a screw. And so you'll make an open approach here. You'll make sure that you identify the course of the ulnar nerve, and then using a direct reduction and direct fixation there, it's probably the safest way to get these fractures to heal without having those iatrogenic complications with the nerve.
Yeah, so not as commonly fixed, but certainly some indications listed here. So that's all for elbows. Any questions, Phil?
We're
I
good.
think we were going to dive into a little segue, a little bit on casting, but maybe in the interest of time, I'd love to cover the ankle side of it. Maybe we can revisit this at the end if we do have time. But let's dive into the ankles real quick, and then Trey, why don't you take us through the distal tibia physis and how it relates to ankle injuries in kids?
Yeah, we're gonna shift gears. We're gonna go from the elbow down to the ankle, but the kind of the same fundamentals remain. We're going to be continuously talking about patients that have ligaments and tendons that are stronger than the bones. The physis is going to be the weakest point. And that's where the injuries that you see around the ankle are going to be a little bit different than what you see in adults. With the closure of the physis, just like what we mean by closure is basically the way that the bone goes from being skeletally immature to mature. There's bridging bone that goes across the physis. That makes the weakened areas different as you progress through this from left to right. You start from the posterior medial side, anterior medial to the posterior lateral, and then the anterior lateral. And you're going to see with these different types of fracture patterns why that's important, but then also how that's going to dictate how you treat these things and where you're going to expect to see the fracture lines go through. Because we're always just taking the force through whatever structure, whatever bone is broken, and we're trying to see what things are tension and what things are compressed. So you can just progress to the next one.
Yeah,
if I can jump in
and that's
real
where
quick.
we really want to understand the difference between these two, because I think it can be really confusing. So how do you separate them in your mind?
Well, the Tillaux is going to be the older patient. It's a very last little bit to ossify. So you're going to have this avulsion of that anterior lateral epiphysis. We're going to show a couple of cases here in a second, but the triplane fracture is when you have a more skeletally immature patient, and the failure goes in several different planes. It goes through a coronal plane, axial plane, exactly, and then a sagittal plane where you are having different types of fracture lines that look like different things on different x-rays. So if we took this triplane fracture, and you can see all those different planes, the different lines that are being drawn by that fragment. If we took different x-rays of that, on every single view, it's going to look a little bit different. It's going to be a Saltair's 2, remember, they go through the metaphysis, that goes through the coronal plane that you're going to see on the sagittal view, or the lateral view. It's a Saltair's 1 because it cuts across the physis, and then it's going to be a Saltair's 3 where it goes through the epiphysis on your AP view. So exactly, this case right here, and that I think Brendan's going to talk about in a second, kind of shows how that fracture makes a zigzag going through the bone and creates a bunch of different pieces that are unique to kids.
Yeah, so this is a great example of a triplane ankle fracture. This is a 13-year-old male after a football injury, twisting injury as he was going down tackling somebody and someone landed on him. Unfortunately, came in 5 days out. This was discharged from an ER, and this patient had complete loss of sensation to the dorsalis pedis region of his foot. Again, if we're understanding trauma is not just a bony injury, but the soft tissue injuries that are associated with it. And so you can see the displacement in the sagittal plane on the lateral here. You can imagine, just like we had the diagram before with the elbow, the neurovascular bundle anteriorly is being tethered or being stretched by that anterior metaphyseal fragment. And so really trying to make sure that we're assessing soft tissues in association with these fractures is important. You can see the three components, the Saltair's 2, Saltair's 1, and Saltair's 3 components that make up the triplane ankle fracture, and then this one had an associated fibula fracture as well. So this patient was ultimately taken to the operating room. We attempt closed reductions on these, but this patient
that's what I was
need
going
to
to ask.
proceed with an open reduction. To Trey's point, these are the younger patients, and so the physis is still open. And so if we can respect that physis without crossing over the physis or tethering the physis, we try to do so. So you can see the fixation construct here includes a lag by design screw within the epiphysis where that fracture exited through the medial malleolus. We have 2 A to P screws within the metaphysis, again, respecting the physis itself, and then trying to add some stability to that fibula, an intramedullary device, but a smooth intramedullary device crossing the physis so as not to create a physeal bar or to shut down that distal fibular physis. Ultimately, he went on to heal well. He did have progressive closure of his physis, but it was mirroring that of his contralateral uninjured side. As expected with a retained intramedullary implant that was a little proud. Surgeon could have buried that a little bit more. He had some prominence there, and so went back for hardware removal. This kid is back to football, back to doing everything that he enjoys without any pain. So overall, a good outcome, but certainly a bad injury when it comes in, and something that we should be mindful of where the injury pattern is occurring and how to fix that while still respecting the growth plate.
What are the chances that you can get a closed reduction at 5 days out on that sort of injury?
5 days out, very low.
Yeah.
So acutely and commonly, you can get a good reduction with these. The problem is with the amount of swelling, the amount of soft tissue, and the periosteum that can flip in there, there's often rebound. And so as a resident, you may get a great reduction. You're feeling really good. The immediate post-reduction x-rays look great. but a subsequent CT scan sometimes shows that rebound and shows the redisplacement. That's nothing that you did wrong. That's just a soft tissue injury that's impairing maintaining that reduction. It's too unstable not to be fixed.
Perfect. And so then the Tillaux are a bit different. And you were gonna run through that one, Trey.
Yeah. So the AITFL, know what these acronyms mean. It's anterior inferior tibiofibular ligament. So you want to make sure that you are understanding that the ligaments in these kids are going to be stronger than the actual bone themselves. And so if you're thinking about these ankle fractures, if there's an external rotation moment, it may avulse that fragment as opposed to tearing the ligament like you would have in adults. And it's going to be a Saltair's 3. Remember, it's going through the epiphysis and this is exiting the physis. So these are things that we're going to take into consideration, particularly when we're worried about the epiphysis and the articular reduction. These x-rays, you might not be able to see it. It's really small. But I think this is Brennan's case. And yep, there it is. If you see the patient's 13, you see the medial physis is already starting to close, the distal fibular physis is closing. You can identify these fractures and know that you might need to get a little bit more work.
Yeah, and so looking through the plain films here, you see subtle lucency through the epiphysis. You're seeing a little bit of step off on the lateral view, which alerts you to something going on there. And so the more that you see these, the more that you'll be able to recognize the subtle widening of the lateral distal tibial physis there, as well as fracture line going through the epiphysis. And so you can recognize this as that Tillaux fracture. Similar to the triplanes, you can attempt a closed reduction on these, and with a little internal rotation and a little bit of manipulation, sometimes you can get these down to a fracture that does not need surgery. But commonly, these going through the articular surface, similar to our previous fractures, we need an anatomic reduction. And so CT scan is useful in evaluating what that gap is at the fracture site. And really, much like our other fractures, both in this session and other sessions, any step off or any gapping greater than 2 millimeters at the articular surface is going to portend worse outcomes. And so we try to get that better through surgical fixation. She was ultimately taken to the operating room, a small open direct approach at the fracture site. A clamp was applied and a single screw was used to compress that fracture site. The way that you fix these fractures, again, is utilizing your knowledge that the central, the medial, the posterior, lateral aspect of the physis has closed. And so we don't have to be as discreet about only being epiphyseal with our fixation. You can utilize the screw to be much more perpendicular to this oblique fracture, get your compression how you need, and not be as concerned about crossing the physis as you can see here.
Perfect. That's another great example. And so that closes our discussion on the elbows and ankles. And there are a lot of confusing topics, so don't hesitate to go back and watch this over again. But just to recap quickly, PEDS patients are unique for many reasons. Obviously, the physis being almost number one there. And then we learned a little bit about the ossification centers. Although it's a lot of information, it's going to be something that you're going to have to review over time and throughout residency. And then we really want to emphasize how important the exam and the story are in terms of your assessment of these patients. And then in terms of pediatric elbows and ankles, you want to know the pattern of closure of the physis as well as ossification, and then utilizing important imaging views to make sure you're making the correct diagnoses and getting anatomic reductions of the joints when they're involved. Any questions to hash out real quick before we dive into one more case that I'd really love to hit?
Yep, I've got one for Dr. Aker, and it is pertinent to what Shannon asked. And she said, is hardware removal standard of care or only indicated in patients having pain or issues? And so my question for Dr. Aker, have you taken care of an adult who had like a plate or a screw like in the middle of their femur from a childhood injury? And have you ever had to do something creative because of that?
Yeah, absolutely. I mean, if you work in this business long enough, you're going to find patients that are 50 years old who they think they had a surgery at some point. They don't remember. Parents told them as a kid they broke their leg, whatever. Yes, I have seen some of those, and decades down the road, there is no hope for getting any of that metal out. So you do have to sometimes be creative and come up with surgical constructs to dodge, involve, get around the existing implants that are typically buried in the bone. Because remember, if you put a plate on a 10-year-old's femur, the femur is not only getting longer, but it's growing circumferentially as well. So ultimately that hardware gets buried in bone. And so if you are planning, I saw Shannon's question and I saw Trey's response. It's a great question because it's not so simple, unfortunately. In general, I think a lot of hardware can stay. It's really a discussion with the family and the parents, and a lot of times folks decide, this child is so young, let's just go ahead and take it out. The morbidity, the potential for complications is so low to just take it out shortly thereafter, and then never have to worry about all the stuff you talked about, Phil, decades down the road when you and I are dead and gone. But it might be somebody else's problem. That being said, currently, to my knowledge, and Trey and Brennan, correct me if I'm wrong, the only profound recommendation for hardware removal in pediatric patients, to my knowledge, is implants around the hip. And that has the potential for long-term ramifications. For example, it's hard to think about when a 10-year-old is 80 years old, but if they would go on to need a hip replacement, it's really challenging to do if there's implants that have been in for decades and decades and decades, and now you need to remove it to do a hip replacement, knee replacement, etc. So did I get that right, or are there new recommendations, guys?
No, that's about right. I mean, that's kind of what I used to. Just if there's anything I'm concerned about with the hip, the femur, if there's a plate that's used as potentially going to tether the lateral side during growth, tend to opt for removal of those. And I always offer to the families, especially the ones that tend to be the most commonly removed, will be anything in the femur, typically is what I end up removing. And then if there's anywhere around the screws that are symptomatic, that medial epicondyle screw that we showed earlier tends to be rather symptomatic. You rest your elbow on the table. That seems to be annoying to people. And especially when we're treating things called tibial tubercle fractures, where people are kneeling directly onto their screws, that can be one thing.
Yeah, I think the big thing is really 3 parameters. If it's painful, it's nice to get it out, as you saw that flexible intramedullary wire. If there's a potential for inhibiting growth, so either we are tethering a physis on one side or potentially crossing a physis with a structure, we should take that out. And then really third plays into your point of, is it going to be significantly more difficult to remove in the future? And if it is, it's worthwhile taking it out. The discussion of taking flexible nails out of the femur, if they never needed another surgery, they would be just fine. But if they ever need another surgery, removing fully intramedullary devices versus those who can simply be grasped through a 2-cm incision, dramatically different. And so I think that all plays into the discussion. You're absolutely right. It's good practice to consider. Some people may need surgeries in the future, and so try not to complicate that for other surgeons.
Excellent.
We should probably come full circle also and say that we didn't really get into the details, but all of those fractures that you were fixing with closed reduction and percutaneous pins, what are y'all doing with those pins? Like, because the pins in your follow-up x-rays are all gone, so I guess you're removing them at some point. How do y'all deal with the pins?
Yeah, so everybody kind of, it depends on what you're putting them in for and what you're fixing, what you're holding. But say for the supracondylar fracture, I routinely remove them at about 4 weeks. And it's in clinic. You put the pins in a particular way that helps facilitate removal, that doesn't cause too much morbidity to your 3, 4, 5-year-old kid that happens to have the screw and pins removed and has to see the pins come out of their elbow. But it doesn't leave anything inside the bone. I think parents tend to like it after it's all said and done. They get a little worked up before it. But if you coach them, you let them know, like, yes, there will be drops of blood. But the kids, by the time they get home that evening, likely will be moving and using it without difficulty.
So we're just gonna hit one more bonus case just to emphasize what's a really important point about certain patterns of injury that we really want you to recognize and key in on and know to investigate further. Brennan, you sent me this case. Can you run through this case real quick and tell us what the thought process is here and what your worry would be? And then any advice you have to handle this scenario?
Yeah, so this was a 8-year-old male who reportedly fell from the bed and presents with this transverse femoral shaft fracture. And as you're progressing through residency, that's something that should raise alarm bells or raise a red flag to you. Really, the recommendation is any femoral shaft fracture in 3 and under, we should be looking at the potential for non-accidental trauma. It doesn't mean that kids don't fall and doesn't mean that kids don't have injuries. They certainly do, but we want to be extra cautious that we're not missing an opportunity to really intervene and change a child's life for the better, just outside or more than just fixing bones. And so this patient came in, we did initiate a non-accidental trauma workup. What that includes is interviews with the child life team, interviews with the social work team, a full bone scan just to make sure that we're not seeing other fractures or previous fractures that are in a different stage of healing. As a resident, this is never a comfortable scenario to be in. But I think if you understand broaching the subject and just being upfront with the patient's parents that we're trying to do what's best for the kid, and we certainly understand that accidents do happen. Most of the parents who have nothing to hide, and it's a very normal occurrence, there was just a bad accident, they're more than willing to participate. If you explain it as, hey, 85, 90% of the time, we understand that this was an accident, but we're really trying to find that 5 to 10% of the time where this wasn't an accident. And so we could really use your help in making sure that we get your child safe and healed and well taken care of. And usually parents are pretty receptive to that, and they understand that it's just part of the process that we have to go to protect all kids. But certainly a challenging topic to broach, certainly earlier on in your residency years as you're just feeling uncomfortable kind of with this, what you feel will be argumentative or combative relationship with the parents. But ultimately, at the end of the day, it's our responsibility to the patient, whether they're 6 months old, 8 months old, or 80 years old, to make sure that they're safe and taken care of.
That's a great way to put it. Yeah. So thanks for summarizing that for us. We'll sort of skip over the treatment of that one. That one was treated non-operatively in what we call a spica cast.
But just real quick, notice on that fracture, that's a transverse femur fracture. It takes a lot of energy to do that. That's not just a random, I tripped and fell and slipped. There is something else that happened to that child that probably should not have. I mean, no kid deserves to get injured, but that is a high energy mechanism in a very, very strong bone. So that's something that should perk your interest, get you thinking a little bit more, get you investigating a little bit more, looking for other injuries. That's what the skeletal surgery does. And you're starting to see if there's any discrepancies in the story.
Perfect. Yeah, that's a good point to make as well. Thank you, Trey. We'll skip through that one. Last but not least, next month, just a quick plug. We're going to dive into a whole nother area of orthopedics yet again. We're going to talk a little bit about hand consults and why something as innocuous as this little, I don't know, poke wound on a finger is something that you should definitely worry more about. And so you'll learn about that and why you should be on the lookout, and that should set off alarm bells for you. So we'll see you next month. Otherwise, until then, don't forget that this recording and all the others are on YouTube, and don't forget to collect your badges as well along the way. All right, guys, thanks so much for your time. It was a fun evening, and so hopefully we all learned a lot, because I did.